Hello, and welcome to our fourth and final session. It's been a real pleasure working with all of you over the course of these previous three sessions. I hope you found them useful, and I'm hoping that you'll find today equally as beneficial. Let me give you a little bit of a heads up as to what we're going to cover in our last session. We have three more diagnoses that we want to talk about. Again, three diagnoses that are maybe a little less common than the anxiety or the depression diagnoses, but nonetheless, these are diagnoses that may also present concurrently with substance use disorder. I just want to make again another just a summary comment, remembering that what we're looking at is, as alcohol and drug abuse professionals, how do we treat the substance use disorder when in fact there might be co-occurring dual disorders as it relates to emotional, behavioral, or cognitive impairment. We're not talking about how to treat the mental health issues. We're talking about what might be the best approaches for you to use as an alcohol and drug counselor. The three topic areas that we're going to go into today are oftentimes viewed by attendees as clinicians as some of the more energy consuming, more difficult mental health diagnoses concurring with substance use to respond to. Again, yes, we do want to acknowledge that these clients present their own unique set of challenges, but always knowing that our area of expertise lies with the substance use disorder. The first diagnosis that we're going to deal with today is taking a look at what is generally referred to as bipolar disorders. Bipolar, just for clarification, is actually the medical name for a condition known as manic depression. It's pretty obvious just from the words manic and from the words depression what it is that we're seeing alternating with clients that have this disorder. A person with this disorder is oftentimes presenting in an extremely elevated, euphoric, sometimes even described as a frenetic mood. And then when they cycle out of that mania, they hit a level of depression that is almost like depression on steroids, an extremely debilitating form of depression. In general, people with bipolar disorders may be described as having moods, particularly in the mania phase, which is oftentimes very similar to some of the same behavioral manifestations that we might see with substance use. Overly confident, overly optimistic, very high energy, recklessness, certainly a level of grandiosity, and oftentimes also presenting as very irritable and unpredictable. Their moods can, it appears as though just flash in an instant from I'm very cooperative and congenial to I'm going to be very demanding, and there's no other way to look at the world other than through my glasses. We do see that manic depression or bipolar disorder is more often than not a diagnosis that we don't really see appear within the medical health world, in the mental health world, much before somebody is in their mid to late 20s. If the symptoms have not appeared somewhere around 40 or 45 years of age, it's also very possible that they've either mellowed out of their bipolar disorder, or in fact, what we thought might have been mania, what we thought might have been severe depression actually could have been another kind of condition. Individuals with bipolar disorder will present sometimes with what is called a pressed speech. The best way to think about that is literally pressing against your throat and feeling as though what it is that you're saying is just like an overexertion to what is the feeling of a restricted throat. They oftentimes will engage in extremely high risk behaviors, little or no impulse control. And that's oftentimes one of the things that can get them into some pretty significant trouble, either financially, can get them in trouble as it relates to their possible relationships, might even result in their getting into some difficulty um, with legal issues as well. The thing that's challenging about the mania mood is that oftentimes in our society, that individual who's presenting in a mania phase actually is a very playful or festive kind of mood. And quite frankly, there are certain industries, there are certain kinds of jobs that really seem to almost be tailor made for the person in the mania phase. High end automobile sales, high end retail sales. We might see an individual in the mania phase become extremely successful in the finance or in the investing world. One of the things that I oftentimes suggest to folks is if you've not really seen bipolar operating in its full blown capacity, I would suggest that if you've not seen the DVD, or if you have and you might want to see it again, to just take a look at the movie Wolf of Wall Street. First of all, it on set again in the star's role in the movie in his early 40s. Was disillusioned and frustrated with his job. He had an opportunity to get into what's called boiler room sales. Was very successful, so much to the extent that he just skyrocketed to the top of that industry, and then from that just grew on into other very, very grandiose, high energy occupations. The thing that happened, of course, is that as he cycled out of his mania phase, the inevitable depression crash was very, very, very debilitating, very, very challenging to his relationships. Again, he was not able to function in his job. He also lost a lot of money as he was going into the depressive stage. And at least in that movie, one of the things that seemed to really draw that star witness or that star character, if you will, to his substance use was trying to put off the depressed mood for as long as possible. And he came very, very deeply involved in stimulant use, particularly cocaine use. If we take a look at the DSM-5 and we take a look at some of the descriptions in the DSM-5 of bipolar, we get, first of all, a list of manifestations, symptomatic manifestations in the mania phase. As I said, extremely euphoric mood, just incredibly excited. The individual sees themselves as having limitless possibilities, does not have a lot of regard for others around him. It's all about what it is that that individual is wanting to accomplish. But again, remember that frenetic characteristic to it. Just a go, 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 a very, very, very hyper vigilant, again, almost an ultra manifestation of anxiety. The individual that presents in a mania phase, as I said, also has sometimes a very elevated self-esteem issue, truly does think of themselves as being limitless in what it is that they can accomplish. They have great visions of grandiosity, and really, again, do believe that there's really nothing that they cannot accomplish. You can begin to see how, with that level of inflated self esteem, with that level of grandiosity, how oftentimes, quite frankly, they're very comfortable interacting with substance users who might be experiencing some of those same manifestations. In the mania phase, people have a dramatically decreased need for sleep. I'm not talking about just a couple of hours of sleep a night. They may go nights without sleep, which is interesting because that very phenomenon itself, A, can also present as psychoses. And that situation in and of itself may also eventually lead to various kinds of substances that they may take to try and help them at least get some degree of rest. The mania phase is an excessive stream of talkativeness. We aren't just talking to chatty Cathy, we're talking about somebody who just is not able to let other people interrupt. It is this stream of consciousness, and they're oftentimes jumping very, very rapidly from one thought to another thought to another thought. Sometimes they will report an experience called racing thoughts, thoughts that are coming so rapidly to them that they're finding it difficult even themselves to keep up with all of their thoughts. Certainly, those around them are having trouble keeping up with them. You may still be trying to process something they might have said even a half a minute ago, and they're already three topics ahead of you. Easily distracted, obviously, this kind of escalated activity, this kind of escalated thought process is going to make it very easy for individuals to be distracted. Probably one of the ways that we might most often see that manifest is they just can't seem to settle down. They can't focus their attention on one thing for very long. It's I'm here and I'm there and I'm over here and I'm over there. And then, of course, one of the other things that we see that's a very common characteristic in the mania phase is an excessive involvement in pleasurable activities. People will oftentimes uh, go way out of their value systems in a mania phase. Um, Lots of sexual indiscretions, spending money that they have that they don't have. I heard of one situation where a gentleman purchased in a mania phase 3 Harleys. And obviously, as if his depression wasn't enough, when the depression hit, it was about the same time he was beginning to be aware of, wait a minute, I just bought 3 Harleys. I have no idea, A, how I'm going to pay for them. And I can only ride one at a time. What was I thinking of? So we may see excessive substance abuse. We also may see them making some very foolish business investments. All things considered, as you can well imagine, when somebody is in that mania phase, it doesn't leave a lot of room in their life for empathy for others. It doesn't leave a lot of room in their life for being considerate of others' needs. It is truly, truly a mindset of it is all about me. The entire universe is here for me. Everything is here for my picking, and I'll take whatever I want from those relationships around me. Now, when we talk about types of bipolar disorders, we do have some clinical breakdowns. Again, more than likely, as alcohol and drug counselors, this is not going to be something that you're going to be diagnosing, but you may see these things presenting. Bipolar 1, for example, is a single manic episode. The individual has this very, very, very high escalated uh, mood swing, uh, completely exhilarated, and the individual then will stay in that uh, cycle. They're called cycles. They'll stay in that cycle sometimes for a relatively long period of time. There may actually be situations where, as alcohol and drug counselors, you could possibly be working with an individual and only know them in a mania phase. Some individuals, their mania cycles last just a matter of a few days. That's probably what is more common is the mania episodes last for weeks, months, and you may never know the individual in any other mental status other than in their mania phase. And then bipolar 2, obviously, the opposite of bipolar 1, would be where the depressive mode, the downward slide into this extreme depression is beyond debilitating. The individual will sleep for days and days and days at a time. They stay in a darkened room. They don't want to have any conversations with anyone. They don't want to see anyone. So again, as you take a look at the overall implications of bipolar disorder on jobs and relationships and productivity and meaningful activity, you can see that it can become an extremely, as I said, debilitating condition. We are seeing, and this is a concern, we are seeing more recently some older adolescents, 18, 19, 20-year-old adolescents who are now coming into our programs having had bipolar diagnoses as teenagers. That's really questionable. There has been some discussion of that in the DSM-5, but generally speaking, when we have an adolescent who has this dramatic mood swing, highs and lows, we sometimes wonder if that's not just adolescence. Those of you that have had adolescence in your lives, or you might remember your own adolescence, I mean, really from day to day, from week to week, it could be very, very high elevated moods, and then it could be really for no reason that you can put your finger on. It might also be extremely depressed moods as well. So let's talk a bit about the frequency of bipolar disorder occurring, first of all, across mainstream America. And then let's talk about it as it relates to the clients with substance use disorder. When we look at the general population and we look at the incidence of bipolar disorder amongst the general population, as contrasted to some of the disorders that we looked at in our previous sessions, we really see bipolar disorder coming in at a relatively low level of frequency. Somewhere between 1 to 2% of the population may in fact be affected by bipolar disorder. It seems to be equally as prevalent in males as it is in females. There's also been some interesting studies that have been done as it relates to the cross-generational occurrence of bipolar. There now seems to be some data that is actually saying that there is certainly a genetic risk that we had not previously seen, that we may have offspring of parents that have bipolar disorder beginning to manifest those same characteristics. But as is oftentimes the case, we also have to look at that as whether or not that's learned behavior. If I've grown up and all I've had around me is chaos, chaos is going to be normal. Chaos is not going to be abnormal. At the same time, if my parent has now gone into this deep, 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 dark depression slide, I'm going to learn how it is that I need to conduct myself in the household so as to not exacerbate that situation at all. Bipolar disorder, so again, affects about 2% of the adult population in the United States. But one of the unfortunate factors about bipolar disorder, even with that 2% of the population, is that unfortunately about 15% of that population don't live into their late 40s, 50s, and so on. Very large percentage of individuals with bipolar disorder actually die from completed suicides. Completed suicides when they've come to terms with or are now confronted with some of the behaviors that they exhibited while they were in a mania phase. And some of the suicide ideation also comes from this overwhelming sense of a hopelessness. I know what my cycles are. I know that this will occur again. I know that I'm going to be in this situation where I'm going to do things that I'm going to regret. I know that I'm going to be going into a depressive mode. And people oftentimes, as I say, reach that, that place of just hopeless despair. I can't continue on doing this. Individuals with chemical use issues, individuals that have alcohol, recreational drug, or misuse of medication issues are somewhere between 8 to 10 times more likely than persons without a bipolar disorder. So there is a strong correlation between bipolar and substance use, in large part because in many instances, the person that's struggling with either one of their cycles is attempting to use medications to some degree to manage that. They like the mania. They like the mania. It's starting to escalate. They're feeling like they're top of the heap. They're better than anybody else. They can accomplish what nobody else can accomplish. They have, however, had enough cycles that they know that there is a point at which when they go beyond that desirable state, that they just get too unmanageable. They can't manage themselves. Other people can't manage them. They begin to get into significant problems. So we do have some individuals, as they're peaking out in a mania phase, will use certain substances to just cut the curve a bit. Just cut the curve a little bit. So we might see things like alcohol, we might see cannabis, we might see some benzo use, we might see some barbiturate use. And then, of course, we have the other extreme, and that is individuals as they are getting now down to the downward slope. And again, they've been there before, so they know what's coming. They know that there is a depression crash that is incredibly distressing, very, very disabling, sometimes brings with it even a significant amount of physical pain. And so they'll try to hold off that depression stage for as long as possible, again, by using stimulants. So they're kind of getting into this. I'm attempting to dance with my mental health condition, manage my mental health condition by my choices of substances. Nonetheless, studies indicate higher rates of substance use disorder among individuals with bipolar disorders, and conversely, a higher incidence of bipolar disorders amongst individuals with substance use disorders. You are going to see them. They will be certainly in your programs. Now you have a visual as well that gives us at least a picture of a little bit more of the co-occurrence of bipolar with substance use disorder. We have some statistics as it relates to bipolar 1. Remember, that is the mania phase. It's estimated that about 60% of the people with bipolar 1 may also present with a moderate substance use disorder. Many of those individuals, as it relates to their drugs of choice, whether it's in the mania phase or whether it's trying to circumvent the depressive stage, as we see from the statistic, will also gravitate to stimulant use, particularly cocaine use, as a way to try and either justify. One of the things that they'll do is they'll oftentimes justify all these bizarre behaviors. Well, I would never have done that had I not been ripped. I would never have done that had I not been high on cocaine, as opposed to, I made an error in judgment, I have inappropriate behaviors, I have less than pro-social behaviors because I have a mental illness. Now that takes us into another point of discussion as it relates specifically to bipolar disorders. Are there medications? And if there are medications, what is currently seeming to be most successful? And then what are some of the counseling approaches that are used as we attempt to try and do talk therapy, behavior management therapy with the individual with bipolar disorders and substance use disorders? Generally, the symptoms of a bipolar disorder that last more than 14 days, once the individual has detoxified from their drug of choice, and we still are seeing these bipolar manifestations, particularly the mania, there's a fairly high probability, excuse me, that psychotropic medications could potentially be beneficial. The most common medications are used to control the symptoms. There is no medication that will cure or eradicate bipolar disorder. But we can look at medications that are mood stabilizers. We can look at medications that are considered anticonvulsants, just calms down a lot of that chatter that's going on in their brain. And then, of course, medications when they've gone into the depressive stage that might help them with their severe depression. It's only been recently, within the last 40 or 50 years that we've even had a medication that has proven to have any degree of effectiveness in working with individuals with bipolar disorders. That's a medication that was first introduced in the 1940s, and it has since become pretty much the preferred go-to medication. That medication is lithium carbonate. One of the challenges that we have with lithium is, of course, finding the right dosage. Too much lithium, people are going to just sort of sit in a clump, possibly drool down the side of their mouth. Nobody home, no interaction, no conversations, no activity of any sort. So we don't want to medicate people to the extent that that's what they're experiencing. Sometimes you'll even hear the term the lithium shuffle, just that sort of very slow, old man, old lady kind of just little teeny, sliding one foot in front of the other, as opposed to picking up their feet and walking in a more intentional way. So here we have this medication, lithium carbonate, does seem to be really, as I said, about the most preferred go-to medication, um, but it certainly also has uh, some negative aspects to it as well. Now you can see on your handout, you can see on the screen that there are a couple of other medications that will sometimes give individuals some degree of relief from the mania. We're talking relief from the mania. One of those is Tegretol. Tegretol is a medication, again, an anticonvulsant, kind of just slows down all of that activity. Klonopin would be another. You see Klonopin on the screen is in red. The reason Klonopin is in red is that it has a very high abuse potential to it. So again, people wanting their benzos, people wanting their Klonopin, not necessarily because they have a diagnosis that warrants that, but they just want to check out. And that's always a challenge when we're working with individuals in alcohol and drug treatment. Is the cure worse than the condition? Is the medication that we're prescribing or having prescribed more counterproductive to us talking about addiction messages than no medication at all? And then, of course, when we get into the depressive mode, what we would look at in the depressive mode, back to our discussion earlier when we talked about SSRIs as a very effective medication for depression. This is going to be one of the things that we're going to also see prescribed as individuals begin to move into that other cycle, that other part of their bipolar disorder, which is extremely painful, extremely severe, disabling depression. So it's a dilemma for us. We don't have one absolute fabulous medication. We've got some things that are tried as it relates to the mania phase. But I will tell you, when somebody is in a mania phase, having them sit calmly in a therapy group, having them engaged in a very meaningful way in a one-to-one counseling session is going to be a real challenge. So again, there are going to be times, and I mentioned this earlier, I mentioned this our first session together, there are going to be times when, particularly in the bipolar disordered individual in the mania phase, we really want to put any unrealistic expectations of cognitive therapies, talk therapies, on the back burner. Just getting this individual to be able to calm down enough that they don't do harm to themselves, that in fact they don't do harm to others, is oftentimes the most that we can accomplish. Once that mood has been stabilized, before they get into their serious depression crash, we might be able to look at some change talk. But again, this is going to be a much more challenging client to work with. We have a very small window between the mania phase and between the depression phase when we might be able to work with them therapeutically. Nonetheless, we don't give up. Nonetheless, we certainly want to look at what might be some of the counseling approaches. So let me just walk you through some of those thoughts. I sure wish we could have more dialogue together. I'd really like to hear what some of your experiences have been in working with individuals that struggle with bipolar disorders and substance use disorders. You might be able to reference that in today's homework assignment. If so, please bring up some examples of cases that you've worked with. But let's talk about overall counseling approaches. First of all, as dismal as it sounds, we do need to say there is no cure for bipolar disorder. we cannot make it go away. Mental health professionals do not have a method in which to make it go away. There have been some pretty extreme strategies in the mental health world that have actually been tried with bipolar. There's been individuals, quite frankly, for whom electric shock therapy seemed to have been the only thing that was able to eradicate their mania or pull them out of their deep, deep depression slide. But nonetheless, the only approach then might be to look at medications that would be mood stabilizers, and then some therapy that we can provide them, some understanding of their condition, some recognition that there are other people in the world who have this condition. There's a tremendous amount of shame that we will oftentimes see with the bipolar individual. People do things, they do things in their mania phase that are outrageous. I mean, very, very, very out of character, extremely high risk, puts many aspects of their life in serious jeopardy, can literally ruin their reputation, ruin their careers because of the behaviors they engage in when they're in a mania phase. So again, we don't want to overlook the importance of stabilizing that, but also helping them recognize this is a neurochemical phenomenon. It's something happening in my brain, and I am not the only person in the world who suffers with this. Sometimes just support groups for that reason and that reason alone can be a very, very valuable part of the treatment experience, providing a forum, first of all, so that I can have self-acceptance, understand what my condition is, and then I can be with other people in my support group who are also going to accept me, even though I've done these things that otherwise would seem extremely outlandish. And as I'm in this therapy group with other people, and I hear other individuals who are also struggling with bipolar disorder say things like, well, I don't know if this will help you, but this helped me. I know this is something that I really resisted, but when I started doing it, it really worked for me. Just that whole self discovery piece that can come about as it relates to support groups. The challenge that we have in our substance use disorder world is it's not impossible. It's not an impossible task, but it's very, very challenging to find a substance use disorder recovery group that also is sensitive to bipolar issues. There may be one or two individuals who are also sitting in that therapy group, very quiet. They aren't sharing with anyone. I'm diagnosed with bipolar disorder. And a large part of that is just as a result of the shame. But there are some other things that can be done that might be beneficial as well. Talk therapy, psychotherapy can play an important role in reducing stressors. And it's oftentimes the stressors, feeling overwhelmed, my plate's too full, I can't get everything done that I want to get done, I'm never doing this good enough, somebody's going to always criticize me. Psychotherapy can play an important role either in a one-to-one encounter or in a group encounter with being able to identify stressors as triggers and learn ways to manage one's stressors. Stress management, obviously, is something that is a part of many of our alcohol and drug treatment programs. Mindfulness is another strategy that is oftentimes very, very beneficial in helping individuals mitigate to some degree the stressors in their life. And then, of course, the talk therapy that one might find beneficial as they are approaching, probably not realistically while they're in a depressive episode, but as they're approaching a depressive episode or they're just beginning to leave a depressive episode. Sometimes having talk therapy as a place to just process that. You don't understand how awful this is. You don't know how much I regret what's happening. Have no idea how I wish my life was different. I didn't mean to say those things. I didn't mean to do those things. Again, much of that guilt and shame. But there are some general considerations as well. So let me just hit on a couple of the general considerations when we're working with clients with bipolar disorders. Obviously, the more in-depth diagnoses, the medication prescribing, some of that therapy that is going to be much more geared to their mental illness, as opposed to the therapy that you're going to be able to provide to them geared to their substance use. Know what your lane is, stay in your lane. But some of the general considerations when we're working with individuals that have substance use disorder and bipolar, possibly other diagnoses. I mean, when we talk about dual diagnoses, it doesn't mean that we have just bipolar and just alcoholism. We may have more than one of these running simultaneously. But in general, some of the talk therapy that really helps an individual come to terms with accepting both of their conditions, accepting both of their disorders, being med compliant. What does being med compliant mean? How best might I be able to find a medication that might assist me with my mania or my depression, and also finding a medication that might help me with my craving, or a medication that might be an antagonist to my drugs of choice. So accepting both disorders, being med compliant, understanding what the process is that's happening to them. We can't have behavior change till we have insight. We can't have insight until we have knowledge. So certainly knowledge is going to be a key piece. Because there is a lot of grief associated with bipolar disorders, oftentimes the therapeutic approach is looking at the things that one has done in the mania phase, just as we look at the grief and loss of things that one might have done in their substance use realm. So grief work, loss work, grief and loss support as it relates to the substance use is something certainly as alcohol and drug counselors you can provide. This is where we use the expertise of our mental health professionals to also help them process through the grief and loss that has come from their mental health condition. One of the things that's oftentimes a very important strategy in working with bipolar is really helping people begin to monitor their cycles. Again, as I said, the highs and the lows, the highs and the lows, those are called cycles. And people do eventually begin to have, for lack of another word, I'll use auras, an awareness of, I am starting to get into some of my mania mindset. And there are some things that I can do to try and keep that at bay for a while, as opposed to just flagrantly turning myself over to it. So being able to chart one's cycles, their episodes of, and how frequently their episodes of mania and depression are lasting is going to be another, just a real helpful piece for people to understand. It gives them a somewhat of a sense of some degree of control over what it is that's happening to me. I understand what's happening to me. I understand where this is going. I know where this has gone in the past. I'm pretty sure I know where this is going to go in the future. I think part of the therapeutic issues are also addressing family or interpersonal problems. There may well have been some real impairment in family relationships, in social relationships, in work relationships. First of all, when somebody's in a mania phase, they're not just a really very nice person. And they may have alienated folks because of their behavior related to their mania. And we can say the same thing about the depression, and we can say the same thing about their substance use. So we now have a triple whammy. We have either mania, we have either depression, or we have substance use disorder, all of which can wreak its own degree of havoc on important relationships. Another piece, by the way, in addition to helping individuals process grief and loss, is also to help them come to terms with shame. Again, individuals oftentimes in a community are very well known. The community knows, oh yeah, there's Frank again. He must be on one of his mania moods. And people can handle that to some degree with some empathy. But when every time Frank is in one of those mania moods, there's somebody or something that is likely going to be destroyed. People get impatient with that. So the shame of my behavior is certainly a part of that, particularly as it relates to bipolar. It does seem to get increasingly more severe as a person ages. Their mania moods become more and more and more incapacitating. Their moods of depression become more and more and more incapacitating. If there's any plus at all to these, oftentimes getting worse with age, as a person ages, they're oftentimes not able to engage in some of the more outrageous leap buildings in a single bound kind of behavior that they might have been doing when they were younger. And then finally, as another important counseling approach, again, bipolar mania, bipolar depression, or substance use, is to help people really embrace the idea that this is a lifelong condition. You will have this condition for the rest of your life. Oh, but can't it just go away? Isn't there something that can be done that will make it go away? No, no. All we can do is teach you, support you, assist you in finding more and more and more ways to manage it. Recovery management. How can I manage my substance use disorder? How can I manage my depression? And how might I be able to manage a little more effectively the mania that's going along with this diagnosis as well? Again, one of those client populations that really is going to challenge us as the provider. One of the things that can challenge us as the provider is that we so want for the individual to begin to experience some degree of relief from these symptoms. And for some individuals, it's just not in the cards. This is the hand you were dealt with. This is the situation you're going to have for the rest of your life. What are some of the techniques that can be taught to you that will help you better, more effectively manage that? Now that takes us, as you can see from the slide, into another topic area. And this is where we're going to talk about personality disorders. One of the things that always amazes me as I do this training is that there's inevitably someone in the training group who goes, "Oh, good, we're finally getting to personality disorders. I just love them." Really? Oh, yes, they're so challenging. I just never know quite what to do, and every day it's an adventure. Well, that's true. That is absolutely true. When we're working with individuals with personality disorders, we have an individual that is oftentimes totally engulfing all of your energy, all of your grit, all of your creativity, testing you, constantly testing you. Now, specifically, when we talk about personality disorders in just a few moments, we're going to talk about the two most prevalent personality disorders. There are many. The two most prevalent that we see are the antisocial personality disordered individual, which, by the way, in many ways looks quite a bit like some of our substance use disordered clients. And then we have the borderline personality. Both are a handful. I get criticized for saying that. I've had people say, "Oh, you need to be much more positive. You shouldn't say they're a handful." Well, people tell me they're a handful. I've known individuals. I've known an antisocial personality disordered individual, a very important person to me in my life. I wish I had known at the time. I wish I had known at the time that that was the condition. This person did not have a full-blown diagnosis, and I did not give credence to what it was that they were going through. I thought they were just being a jerk, to put it frankly. Now, before we talk about personality disorders, we have to set the table. And we're going to set the table with looking at personality. So just a couple of comments about personality. We all have one. We all have a personality. Our personalities really began to flourish and bloom at about the age of 3. If you've been fortunate enough to have more than one small child in your life, more than one son or daughter, you've had more than one grandchild in your life, you may well have experienced the piece that I'm going to describe next. I just can't believe how different these two kids are. They were raised the same way, but oh my gosh, they're so different. Yes, they are. They are very different because they each have their own unique personality. Personality, in the simplest of terms, keeping it real basic, personality describes those deeply ingrained patterns of behavior, as well as the manner within which we perceive ourselves and we perceive our world. That's what makes up our personality. Some of us have deeply ingrained patterns of behavior where we're very outgoing, and we were very outgoing as a 3-year-old, and we're very outgoing right now. Some of us, however, have had deeply ingrained personality patterns of behavior where we were much more reserved. We were a little more shy. We didn't like a lot of stuff going on around us. And as a result of that, those patterns of behavior then affect the way one with that personality interacts with others. Similar personalities, we're going to act certain ways. Very different personalities, we're also going to act certain ways. So when we start to take this universal concept of personality, and we start then to look at personality disorders, This is where one's pattern of behavior, one's worldview is oftentimes very rigid, very rigid. There's no, we could do it this way or we could do it this way. No, we're going to do it this way, my way. Inflexible, very, very maladaptive. Now, there are those of us who are a little more type A, we're a little more rigid, we're a little less flexible. But when we talk about personality disorders and we're talking about rigidity and inflexibility, what we're talking about is patterns that are so severe that there's a very high probability that my behaviors are going to drastically deviate from what is considered the norms of my culture. Now, this is one of the challenges that we have when we look at something like the DSM-5. The DSM-5 is just about as white as you can get. The subjects from the very, very first publishing of the DSM all the way up to the current symptoms in the DSM-5 have been based almost exclusively, not so much on Caucasians, but on dominant culture. So one of the things that really begs our attention is when we're starting to look at what we think are less than pro-social ways of behaving, we really do need to look at whether or not there are also some cultural influences. We will never arrive at that place of cultural intelligence. Maybe that's something that we can look at an upcoming training in the future. Cultural intelligence is really the importance of us understanding not our worldview, but trying as much as possible to be aware of, open to, non-judgmental about our clients' worldviews. So when we talk about the DSM diagnosis of personality disorders, we're going to see a couple of things happen. We're going to have 4 areas that could potentially be affected. These are reflected in the DSM-4. One is called cognition, cognitive abilities. The way that our brain receives, perceives, and ultimately reflects back our views about ourselves and about others, cognition. Another aspect of that is one's affect. Affect in this respect is much more than a happy face or a sad face. Affect in this context is the range of intensity that somebody might present emotionally contrasted to the severity of the event. So we have individuals, you may know individuals like this. The simplest of little thing, oh my goodness, to them is just catastrophic. I have a friend who used an expression to describe that. He would talk about making a mountain out of a molehill. Some people's affect is real extreme. And sometimes we can tell what's going on with them by that. Other times we have no idea. So some people hide that affect very well. Another aspect of personality is to what degree is our personality assisting us with impulse control? You know, that person with a little bit more of an outgoing, sociable personality may say things that they didn't mean to say. Things might just slip out of their mouth that they didn't mean to have slip out of their mouth. They might have a facial expression that somebody misinterprets. Impulse control is also influenced by our personality. If, however, I am more of a shy personality, more of a reserved personality, I might be doing flip-flops internally, but you would never know it from the outside. Steady as a rock. No indication whatsoever that something is going on that is challenging that individual. So when we talk about enduring patterns, we're talking about how we think, how we feel, how we present. And then we're also looking at that as patterns. There may be a time when, for whatever reason, you acted so unbelievably out of character. Wow, that just wasn't like you at all, but it's not a pattern. When it's a pattern, well, I am repeating that. I am repeating that again, and you can count on me repeating that again. And so we talk about patterns, enduring patterns of inflexibility, enduring patterns of not necessarily being consistent, cognizant with what we're saying and what we're doing. We may see those when we start to look at personality disorders as well. So again, obviously a huge area of study. Personality, what is it? It's that piece that makes you the absolute awesome, incredible, unpredictable, wonderful, lovable human being that you are. Some days you're working on all four burners, you're doing really well, and some days not so well. But that's different than personality disorders, antisocial personality disorders. So let's take a look at what is meant by personality disorders in general. We actually have three broad categorizations of personality disorders. Again, not all of these are we going to see in a substance use disorder treatment program. As a matter of fact, we're going to see less of A and we're going to see less of C in a typical alcohol and drug treatment program. Cluster A's. Cluster A's, whoa, they are odd. They are very eccentric. We've had one of our 90-degree days and they're walking down the street in a snorkel parka. They have on sub-zero temperature boots, and they're talking very in an animated sort of way to this mysterious person that they see next to them that nobody else sees. Odd, eccentric, tends to move away from people. Ted Kaczynski, the Unabomber, was a cluster A. Odd, eccentric, was living out in the woods, living out his vengeance, his paranoia, his schizophrenia by creating bombs and sending them to people that he thought were out to get him. Odd and eccentric. You will tend not to see them in treatment. Unfortunately, one of the things that happens sometimes is that your treatment programs get dumped with them. My hope for you is if that happens for you in your treatment program, that your managers, your directors are able to say, we just do not have the expertise. We just do not have the resources to help this person. We must make a referral on to another provider. They're usually such high maintenance, consuming so much of the practitioner's time and energy that it's oftentimes to the exclusion of others. They could, in some circumstances, boy, I'm hesitant to say this, but they could, in some circumstances also be dangerous. They view things in a way that is not the way the rest of us view things. They hear voices telling them to do things. They see things that nobody else sees that could cause some pretty disastrous behaviors on their part. But let's roll down to cluster C. Cluster C. Anxious, fearful. Generally not able to function on their own. Our cluster C folks, at least historically, have been those individuals that we have seen in our state hospitals. These are the individuals that may spend a fairly large portion of their life in a psych ward. They're being medicated, they're being taken care of, but any expectations of them being able to be out on their own taking care of themselves is probably less likely to occur. So what does that leave us with? That leaves us with the cluster B. The cluster B people are going to be more likely to come in contact with you. You're going to be more likely to come in contact with them. We have 4 of them listed here. We're going to talk about 2 of them in more detail as it relates to substance use disorder. But let's just do a quick summary of both the histrionic and the narcissistic. The histrionic is the person, if you think as a child, a nursery rhyme, Chicken Little, the sky is falling. Oh my God, the sky is falling. And she warns everybody in the barnyard, oh, you better run and hide, the sky is falling. Hysterical, that would be another way to think about histrionic, hysterical. Not just once or twice, but a pattern of hysteria. Again, more often than not, pretty difficult to work with. Not impossible to work with in a substance use disorder program, but they're going to be less frequent. And then, of course, we have the narcissist. The narcissist does believe that, in fact, the entire, not just the universe, the entire galaxy evolves around them. I am the center of everything. I will get my way. I will do whatever is necessary to get my way. I don't care who I have to hurt to get my way. They're dishonest, they're manipulative, but it comes from the belief system that they are just perfect. There's absolutely nothing wrong with them. They know everything. They know how to handle everything. At the risk of stepping on toes, we've had some discussion, certainly in the last 18 months, that we have had some political figures who might have a pretty significant touch of narcissism. But talking specifically about our clients with substance use disorders, it brings us then to cluster B, the antisocial personality, and the borderline. So let me talk about the antisocial personality disordered individual first. There is no better way to describe them than their name, antisocial. They are not pro-social. They have no sense of what is appropriate, responsible behavior. Many of these individuals actually started to develop some of those characteristics in early adolescence. In early adolescence, we would have referred to them as conduct disordered. if they have been able to get the appropriate therapeutic interventions, if in fact in their antisocial behaviors they have not created such havoc that they now are incarcerated for a life sentence, um, they're out and about in our communities. Um, one of the characteristics about the antisocial personality disordered individual is that they have no sense of somebody else's rights, just not in their cards. I'll take whatever I want whenever I want it. I'll step on whoever it is that I need to step on to get what I want. They tend to infringe on the rights of others. They are going to have some challenges, obviously, in their relationships because they infringe on the rights of others. And antisocial personality disordered individuals also tend to have pretty rocky job performance histories. They're great interviewers. Oh, they can interview, and they're in the job for 2 or 3 days, and they're already telling management, I hope you know when you're out of the office, these are the things that happen. And I hope you know that I have some suggestions as to how it is that this company can be more productive. And I need to tell you that I have seen this happen before, and I have some suggestions, blah, 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 blah. Antisocial personality, they're just really tough to get along with, tending to infringe on the rights of others. By 30, having a fairly extensive police record. They may not have had incarceration as a felon, but they certainly have had many scrapes with the law, and thinking that they were justified. You know what I did? Yeah, it was against the law, but they had it coming. I mean, that's a part of their antisocial personality. You had this coming. Had you not talked to me like that, I wouldn't have felt like I needed to do this. Very vindictive, very revengeful. There are some general symptoms of antisocial personality disordered individuals. I'm going to walk through these, and as I walk through these, I want you to just go tick, tick, tick in your mind and identify for yourself whether or not any of these dynamics have presented themselves as you're working with clients. One, they tend to be easily bored. All right. They need constant stimulation. They aren't going to be able to sit for a psychoeducational lecture for much more than 10 minutes. They're going to get restless. They're going to get up. They're going to need to go to the bathroom. They need to get a drink of water. They're messing around with other people. They're distracting other people. Constant stimulation. And they are charmers. I think that that's maybe one of the things that really jumps off the page. They are very charming. Now, one of the things that we ask clients very typically in alcohol and drug treatment is, where would you like to be? Oh, let's say even a year from now. I don't know. I don't know. Certainly not here. But other than making that kind of a sarcastic remark, this isn't just their being obstinate. They aren't able to make any kind of long-term commitments. They aren't able to set any long-term goals. The antisocial personality disordered individual is right here, right now, in the moment. They refuse to accept responsibility, not they're reluctant to accept responsibility. Well, I wouldn't have gotten the DWI if the cop hadn't been laying for me. Yeah, I wouldn't have beat up my old lady if she hadn't had it coming. Yeah, I wouldn't have whatever. Everything is somebody else's fault. They rarely experience any sense of guilt or remorse, and they absolutely cannot be empathetic, which is a real challenge in an alcohol or drug treatment program, because a lot of what we base our change model on is asking people to take a look at what have been some of the consequences of your use. How has your use affected others? Well, it hasn't. They didn't like it, they could leave. They were using with me, so what's the problem? Unable, an inability to be empathetic. Now, again, if we were sitting around a table having a cup of coffee talking about this, I would venture to guess that there's at least a couple of you that would go, oh my God, yes, I've had this and I've had this, and oh, I've had that too. Doesn't automatically give you diagnosis of an antisocial personality disordered individual, but boy, it starts to reveal some things that might be worth taking a look at. So how frequently is this happening with substance use disorder? Well, quite frequently. And one of the challenges that we have oftentimes with the antisocial personality disordered individual is a lot of these behaviors could also look like addiction behaviors. It could look like that same arrogance, that same, I don't care what happens to anybody. I'm just here all about me. My stuff is about me. So sometimes it's tough. It's like, was this substance use or is this antisocial personality disordered? This is where you need to bring in your mental health professional. You can say to them, wow, this individual's presenting with a lot of what looks to me like could be antisocial personality disorder, but I'm not qualified to diagnose that. Mental health professional, I need your help. Stay in your lane. Stay in your 12 core functions. So what's the incidence and prevalence of antisocial personality disorders? Well, again, we tend to see antisocial personality disorders really come to full bloom in their late 20s through their mid 40s. And in reality, we have the same drill with this that we had with the mania of the borderline personality disorder, which is the behaviors of carrying out an antisocial personality disorder are very, very energy consuming. So people may still have that diagnostic condition, but quite frankly, their behaviors are becoming a little less antisocial, a little less out of the norm of what's considered appropriate. Imagine you're putting a couple of those people together with a couple of those folks who are substance use disordered severes. They feed on each other as well. They can perpetuate the behaviors. Again, seems to be equally consistent between males and females. And then we look at some real specific statistics. About 20% of the people with substance use disorder, about 20% of the people with substance use disorder also meet the diagnostic criteria for antisocial personality disorder. Is that their substance use? Is that their mental health issue? That requires the work of a mental health professional to do that diagnostic work. It does appear, however, that the antisocial personality disorder does seem to present most often with the cocaine using, crack using, or heroin using client. Well, those are relatively antisocial substances to use. Not in every community, not in every sector. But that might be one of the things that we also see is with this personality disorder, we also are seeing some of the more classic characteristics that we might see with stimulant use or opiate use. People with antisocial personality disorders are more often than not polysubstance users. Oh, they don't have just one drug of choice. Oh no, they have they have several substances of choice. People with antisocial personality disorders do tend to gravitate toward the illegal drug culture values, the illegal drug culture community, because quite frankly, the views of drug traffickers, cookers, dealers seems to be relatively consistent with antisocial personalities and the drug culture. You've got a picture here, again, a statistic showing us that about 83% of the individuals with antisocial personality disorders also presented with some form of substance use. Serious enough, substance use serious enough to warrant treatment. So what do we do with this client? This is not an easy client to work with. Are there medications? No. There are no medications that are normally used because in general, they seem to not have any kind of effectiveness over any significant period of time. Where we would see medications being used is if, in fact, we have an antisocial personality disordered individual who has a lot of difficulty with impulse control. We have an antisocial personality disordered individual who's struggling with aggressiveness or depression. There may be some medications, not without a whole lot of success, but there might be some medications that to some degree will take some of the edge off of the antisocial personality disorder. So we're kind of stuck with counseling techniques. How do we counsel? How do we counsel this individual? Well, first and foremost, probably our best bet is to try to establish some kind of therapeutic alliance. I know you don't want to be here. I'm sure you don't want to be here. I'm sure that you aren't all that excited about doing what it is that I'm going to be asking you to do. What do you want? What do you want? What do you want from this treatment experience? I just want everybody off my back. Well, I can't assure you of that, but assuming there aren't any problem behaviors that we need to deal with, assuming that you are not aggressive or potentially harmful to others, you do what it is that's expected of you here, there's a fairly good probability that we'll leave you alone. The therapeutic alliance, very, very, very important. What do you want? I can help you with that. Here are the things that you'll need to do. As it relates to general counseling suggestions with the antisocial personality, recognizing that power struggles are a part of the disorder, don't be surprised when they take you on. And don't take it personally. They're setting you up. They're creating some sort of a power struggle. You didn't say that to me. You didn't tell me I needed to do that. You didn't tell me I needed to do that by this morning. Roll with it. This is where your motivational interviewing really comes into play. I'm pretty sure I did, but let's just move ahead. Let's just put that aside for now. Let's move ahead. Now, I'm not suggesting that we look the other way around all of their behaviors, but boy, pick those battles very, very carefully. Pick those battles very, very, very carefully. Trying to manipulate you as the counselor, wanting to win the power struggles is a part of the disorder. As is their being hostile, part of the disorder. They aren't going to like you. And that's okay. You're not there to be their best friend. You want to treat them with dignity and respect. Don't expect to get that back. Don't expect to get dignity and respect back. However, and this is again, sort of the where does this end? And it ends with when in fact their behaviors are now coming counterproductive to what it is that's happening with the rest of the clients. When their behavior is so flagrantly out of line with what are the expected behaviors in this agency, we might have no option but to discharge them from the program. Here's the problem. Nobody else wants them. They probably have been to a couple of other treatment centers already. Oh, you mean Bob Smith? Well, I'll tell you, Bob Smith has been here 3 times, and we just haven't seemed to really be able to find what it is that works well for Bob here. I just don't think that we're going to be able to accept Bob into our program. So that's one of the challenges. If we've come to the realization of there is no meeting ground here. There's no middle of the road. They're willing to give 40%. If I'm willing to give 60%, they aren't even willing to give 40%. And we now decide that this just is not, well, it's not ethical. What right do I have to charge them for treatment services when in fact, we're not making any progress whatsoever? Only to know that to get another program to take them can be a real challenge. Unfortunately, what oftentimes happens is because of their extensive criminal history, if they aren't going to be successful in a treatment program, then the only other option that they have, because this is what their probation states, is that they will go to jail. They will then be in jail with other antisocial personality disordered individuals who may or may not get any kind of therapeutic interventions when they're in treatment. Rhonda, I'm teaching a class. I can't talk right now. So behavioral management is one of the options that we have. Defining realistic limits. A few clear but consistently held to rules. And then one of the other things that, interestingly enough, around behavioral management that seems to work with the antisocial personality is one of the very same things that works with a 2 or 3-year-old. Don't reinforce a 2 or 3-year-old for having a temper tantrum. But when they're doing something right, tell them, oh, I'm so proud of you. That was such a nice thing to do. To acknowledge not the inappropriate behaviors because we're merely giving them what they want, a power struggle and attention. Some of them we can't help but pay attention to. But of those that we can, this is unacceptable, We're not going to give you a pass this weekend. This is not something that's acceptable behavior. You signed an agreement when you came in here that these were the behaviors that you were willing to comply with. You have to tell your probation officer that you're not in compliance with the program. And when it's necessary, then we have to follow through on that. Don't set up a rule or an expectation that you're not willing to carry out. First time you set up a rule or expectation, they violate it, and you don't consistently follow through on it, look out. Because they'll try it again, and the other antisocial personality disordered individuals are going to go, oh, wow, okay, great. He got by with it, I guess I can too. And it just can be just chaos running rampant in your treatment centers. Now I need to move quickly because we're getting close to the end of our hour and a half. So I want to talk about the borderline personality disorder. Probably one of the biggest issues for the borderline personality disordered individual is one of the single most significant fears of this person is abandonment. If it's looking like I might be getting kicked out of this program, then I'm going to act up. I'm going to be really naughty so that I at least get kicked out of this program on my terms and not your terms. The borderline personality can run a very extreme. You are the most wonderful counselor I have ever had. Oh my God. If only I'd had a counselor like you when I first started using, I don't think I'd be in this spot today. Only to have them say to you 5 minutes from now, you are a piece of shit. I'm going to file a grievance. I'm going to let the state know what a bad counselor you are. I'm going to shut this program down. That over idealization, oh my God, you're wonderful. And then you're just absolutely despicable. Up and down and up and down. Those individuals, by the way, if you're, well, for example, in an hour and a half training, like you're going to be when you watch this video, and you then go back to your office, your borderline personality disordered people will have covered your office door with Post-it notes. Where were you when I needed you? I needed you right now and you weren't here. And look what you made me do. I cut myself. I've gone out and used. Look what you made me do. I just had sex with the guy down the hall. Look what you made me do. It's all your fault because you weren't here when I needed you. Borderline personalities are oftentimes self-injurious, but not all people who self-injure are borderlines. So part of what we look at when we look at people cutting themselves, burning themselves, pouring caustic chemicals on their skin, what's their agenda? What are they trying to accomplish? Look what you made me do is a pretty classic example of that. Borderline personalities, wow, there's a very high incidence of suicidal ideation, actually completed suicide. I don't want to say ideation. I want to say completed suicide. They did a study with a group of borderline personality disordered individuals. And out of this group of 100, 75% had had 3 or more previous suicide attempts. Attempts are intending to die. I intended to die. You found me too soon. You found me before I passed over. Borderline personalities sometimes will go into disassociative modes. I mean, they may just literally roll their eyes back into their head. All you see is the whites of their eyes, and it's, I don't hear you. I'm not going to talk to you. You're not going to talk to me. That's that disassociation. That's also one of the things, by the way, that some of their cutting behaviors also provides for them. Borderline personality disordered individuals are pretty high risk for sexual acting out. And part of the reason for that is they seem not to be able to distinguish intimacy with lustfulness. Somebody is kind to them. Somebody is compassionate. They think you're hitting on them. And they'll act on that. So again, that difficulty in distinguishing, as I said, between intimacy and sexual activity is going to be a challenge. So what's the incidence of this that we see with our substance using client? I'll just give you one bottom line statistic that sort of summarizes it all. About 2/3 of borderline personalities will have an existing substance abuse disorder. Another study tells us that of borderline personalities, approximately 43% of them in one study were identified as having moderate or severe substance use disorders. So what does that say to me? What that says to me is they're in your programs. You may not have recognized them yet. You may not have had them really challenge you yet, but there's a high probability that moment will come. Again, no medications, none. There's no medications for this. We might be able to give them medication to help them with impulse control. We might be able to give them medication to help them with anticonvulsant behaviors. We might be able to give them medication to help them with depression. Mood stabilizers might be beneficial. But in general, no magic pill, nothing that we can give them that is going to be the answer. So how do we work with them? Let's take a look at some of the suggestions in terms of how we work with them. Some general guidelines. Engagement, patience on your part, not to take their behaviors personally, to recognize that their behaviors are in fact part of their diagnoses. One of the things that can happen with a borderline personality, and we need to be real careful of this, is if we are using confrontational behaviors. This is what I see, and this is why I'm concerned, and this is what I'm asking you to do instead, and this is how I'll be able to help you. Even if we do it in that soft sort of way, that could be enough for them to perceive that as a confrontational message, and they'll split, which really puts you between a rock and a hard place. How do I provide constructive feedback around their substance use when in fact I'm running the risk that they'll split because I'm giving them constructive feedback? So being very, very gentle. You're not attacking the individual. You're not confronting the individual. Same thing with our 2 or 3-year-old. You're confronting the behavior. And then, as you can see from the screen, there are some other counseling considerations that seem to work quite well. Dialectical behavioral therapy is a trained form of therapeutic strategies. It can be done by someone other than a mental health professional. So, if any of you have an interest in being trained as a dialectical behavioral therapist, this might be something that you could bring to your borderline personality individuals. But again, in much the same way that we talked about our antisocial personalities, they will get dumped into your program. And if you come to the realization of we just are not equipped, we don't have the competency, we don't have the contractual relationship with a mental health professional who can work with their diagnoses so that we can work with their substance use, might lead us, unfortunately, to that point at which we say we need to find another referral. And that's very sad because unfortunately, to the individual who has major abandonment issues, no matter how you present it, no matter how you frame discharging somebody from a program, they're going to see it as abandonment and rejection. So you want to be sure that there are mental health professionals that you have in the wings that can help pick up those issues of emotional instability, cognitive impairment, as well as their other mental health issues and concerns. Now, we have some assignments. Oh, yes, we do. You'll see the assignments at the end of your packet. I've not received any assignments from any of the rest of you other than one person from your agency. I'm anxiously awaiting for your assignments from modules 1, 2, 3, and now module 4. Just to review for you, once I've received all of the assignments, we will then be sending you a post-test. The post-test needs to be completed and it needs to be returned. If you'll return it to Eden's Group, eric@edensgroup.com would be your best option in returning your post-test. We'll then look at setting up, at a minimum, of a consultation with you, just to see how this whole process went for you. Was there anything that was particularly useful? Is there anything that you still feel you want some additional information on? We'll schedule those once all of the assignments are in and once the post-test is in. The closing date for this class is September 15th. So folks want to get on it, that would be great. Don't leave it till the last minute. And when we've received everything, we will be sending certificates of completion for 12 hours of training in serving the needs of clients with dual disorders. And again, thank you. It's been odd knowing that you're there somewhere on the other side of that screen. I hope you have found this format useful for you. Look forward to having our conversations in the next several weeks. And let's call it a wrap for the day. Thank you.